So without further ado, good morning, Tina.
Hey, good morning, and I certainly hope I do this presentation justice. Yes, our assistant secretaries, as you pointed out, was called away unexpectedly to the legislature. So again, I'm hoping to do this presentation justice, but I do want to say that I'm really thrilled to be addressing a group of nurses and others. For those of you all who don't know, the Office of Public Health is very much a nurse-driven agency. Our public health nurses and all of our staff are really critical to our local responses. And so again, it's really a delight to be able to address you all. We have unique partnerships in the Office of Public Health with the State Board of Nursing, with our nursing universities. And so again, it's really an honor and a privilege to talk with y'all this morning. And before I go too much into the presentation, that I'm going to be presenting this morning, I just want to tell you a little bit about public health at the local level. We're going to be talking this morning about state level issues and kind of giving you a state of the state with the pandemic and some other really pressing public health issues. But for you all who don't know, the Office of Public Health is an office under the Louisiana Department of Health. We have a wonderful secretary, and Dr. Phillips, who's appointed by the governor. And again, the Office of Public Health falls under Dr. Phillips as one of the offices in LDH. We are represented in every region of the state. In the great majority of parishes in the state, you have parish health units, where again, you have our wonderful public health staff who deliver services on a daily basis, direct care services. We still have TB clinics, tuberculosis clinics in our health units, vaccination clinics, reproductive health clinics for women, WIC services, children's special health care clinics in some regions of the state. So our health units are still very active and vibrant parts of the healthcare system, delivery system in our region, and in great part funded through your state and federal taxes. So thanks for all the support that you give to public health at the local level. We also are essentially, I kind of explain it like the arm of the CDC. So all reportable diseases are reported to the Office of Public Health, and then we take action. Our goal, of course, is to prevent spread of disease. And so in the background, there's always work going on in that infectious disease epi section. I think most people saw it kind of up close and personal through the COVID pandemic, but these things happen on a daily basis when you're talking about hepatitis reports, Shigella, E. coli, pertussis. There's a long list of reportable diseases. And so when you report as a healthcare provider, or the lab or the hospital reports passively on your behalf, it does go somewhere. It comes to us, and we look at all that information, and we address it. And again, our goal is prevention, offering interventions when we can, and letting the public know when there is an issue, which again, you'll hear about a little at the end when we talk about our STD rates, our STI rates here in the state. So I just wanted to give you all a little bit of an overview of what we do in public health. And so sorry, allergies in Louisiana. And so we'll now jump into the rest of the presentation, and happy again to take questions at the end. So first, I'll give an update on the state of COVID in Louisiana. Talk just a little bit about the public health infrastructure grants, but not a whole lot about that. Really mostly discuss where we are with COVID, with vaccinations and rates overall. Talk, something really exciting that we're doing well in Louisiana under Governor Edwards' leadership is our hepatitis C elimination project. So talk about that, our HIV rates, which unfortunately are starting to increase. Also talk a little bit about overdose deaths, which again is a very big public health concern. And then we'll end with our state health improvement plans. And that's kind of ending on a high note where because hopefully at the end of this, most of you will be interested in helping to move our state forward. And that's really going to be through this health improvement planning process. So first, again, we'll talk about COVID and where we are as a state and as a nation. And so thankfully, we're in a better place. Some updates. One is that the federal government has launched a website, covid.gov. So for people in the general public who want to order, for example, at-home test kits, you can actually go to covid.gov, and each family can get a total of 4 at-home test kit boxes, which is 2 test kits per box, so 8 test kits. So if you hadn't already, your family, friends, encourage people to go online and register and get these at-home test kits to keep at hand. While we're not in a surge now, we're all concerned about Omicron BA2. And so, we could start to see an increase in cases. So it's always a good idea to have these at-home test kits, on hand. Same at this website, you can find access to good quality masks that the federal government is providing. And then also locally, where can you go if you're looking for a COVID test? If you have COVID and you're not sure if you should take an over-the-counter pill or an infusion or an injection to help to lessen the severity of your illness, you can get lots of great information at that COVID.gov website. And the other kind of big news over the last couple of weeks, at the end of March, the FDA authorized a booster dose, a second booster dose for people 50 and above and people immune compromised. And we'll talk again a little bit about this in a second, but lots of people were waiting for that go ahead to get a second booster. And so the FDA did authorize its use in people, again, 50 and above and those who are immune compromised, if it's been at least 4 months after your first booster. So again, we'll talk a little bit about that in a second, in more detail. Next slide. So this just shows you the gating criteria. And so if y'all remember those great press conferences that the governor would hold or has held throughout the course of these last 2 years, especially when we get into these surges. These are the gating criteria that we all monitor. So again, all these things happen in the background and you're seeing it, really in the forefront and publicly now with COVID. So this is an example of something our epidemiologist and our Bureau of Health Informatics prepares, we monitor, and you can actually get access to all these slides on our LDH website. We have a great website. And so these just show, I'll go through each one of these indicators in a little bit more detail, but you can see all of the indicators are improving. So very clearly you see we've had 5 spikes or surges with COVID, and we're thankfully coming out of that 5th surge. Our hospitals are decreasing, our percent positivities continues to decrease, incidents, ER visits, all of the indicators that we follow are showing much improvement in the COVID-19 numbers. So the next couple of slides, you can move to the next one. We'll just go through a little of these indicators. Well, maybe do this first and then we'll go to the indicators. This is a new map. And again, it's on our LDH website. And this is something that CDC has made a change in the last couple of weeks. I think it's really important to spend just a little bit of time. So I know we all wonder, we all talk about, should we be wearing masks? Is it necessary to wear masks in public? When, how do we know when it's highly recommended versus, you can just wear one if it makes you feel more comfortable. And so what the CDC has done is they use these community levels, and that's the term. And at the bottom of this slide, you'll see a link. Again, it's on our dashboard and it's updated weekly. So this looks, now CDC is giving more weight to, previously more weight was given to new cases, percent positivity, hospitalizations, death, all of those factors. Now there's more weight given to hospitalization. So understanding that we might see an increase in COVID cases, but what is it doing to our healthcare system? How sick is it making people? Understanding that those are some of the most important factors in guiding what your community risk is or community level risk is. So that's so again, these new factors that again are epidemiologists calculate and it's related to the public by way of these community levels. So in Louisiana, we're at the lowest risk, and that's the green, and most all of our parishes, except for those 3 parishes in yellow. And so the bottom line is, first of all, I'll tell everyone, if, masks, people can, of course, opt to wear masks anytime, especially if they're out in public, if they've got underlying health conditions, if they care for someone who does. It is never a bad idea to wear a mask or face covering, especially if you're going to be in a crowded setting. But the CDC, it's when you're looking at these at the low community levels, which again is most of the state, really the only prevention recommendations from the CDC is that you stay up to date on your vaccinations and that if you develop symptoms or have an exposure, you get tested. If you're in the yellow, when we get to the medium community levels, that's when it's recommended by the CDC that if you're at high risk, you consider wearing a mask when you go out and about. And then when you're at high risk, which we hope never to see again, or at high community levels, then that's when it's recommended that people wear masks outdoor when they're especially in indoor crowded settings. So I say all of that to tell you that for people who are really looking for evidence to guide what they do, this is the newer indicators that are being published by CDC to help people in making that decision. Next slide. So again, percent positivity is continuing to decrease. It's very low, 0.8%. So just, I think that's really the important point here. You all know that when we hit those surges, when we see those big increases in cases, percent positivity always goes up. I can tell you with the Omicron surge at our testing sites, some days we were at 20, 30% positivity, meaning, let's say if a 30% positivity means that almost a third of the people that are coming through to get tested are testing positive. So conversely, looking now, we're at less than 1% of people who are tested actually test positive. So that's great. The benchmark has been 10%, wanted to be below that 10%, and really below 5% has been the goal that CDC has been pushing. And so again, we're thankful that we continue to remain at a low level of percent positivity for testing. Next slide. Our 1 week incidence, this is just new cases. And so again, we're seeing many fewer new cases of COVID diagnosed. This is going to be a little bit trickier to follow now that there's all these at-home test kits. So, which is why I think another reason that they're giving more weight to hospitalizations and severity of illness is going to be more helpful to all of us, because as more and more people are tested at home, we're going to have less visibility on the true number of new positive cases. Next slide. This just shows you the test volumes and the percent positivity. And you can see as when we get to these surges, we see an increase in test volume. We tested more people during this Omicron surge than we had at any point in the pandemic. And now the test numbers are going down, as are our percent positivity. So again, these are things that we always follow. If we start to see bumps up or increases, then we as a health department and the governor's office would start to alert the public that there's something changing. Next slide. Now we're just going to get a little bit into the vaccinations, vaccination rates across the state. And so Louisiana as a whole, 53% of the population is fully vaccinated. In the US, that rate is 66%. So we're not nearly where we should or would want to be, but I think we're making progress. And you can see on this slide, and again, all of this is on our dashboard that's updated every week. And some are updated daily, depends on the data point. But over 5 million doses of COVID vaccines have been administered in the state, which is, I think, a tremendous accomplishment. And I want to pause here to say that, again, nurses have been critical to that, as are, lots of our other partners. For example, the Louisiana National Guard working really closely with us, with the health department over the last couple of years to tackle this. Our goal to vaccinate as many people as quickly and safely, efficiently as possible. And in Louisiana, we have something called Louisiana Volunteers in Action. So many of you likely have volunteered to work with the health department in our vaccination and testing efforts throughout the course of this campaign. So thank you all, because it's a lot of vaccine administered to citizens of our state. So thanks. So again, we still have more work to do, and we're continuing to work to increase our vaccination rates in the state. Next slide. And equity is really been central to our vaccination efforts since the beginning. And again, it's not because I'm a state employee and so ultimately work for the governor of our state. I can just tell you that is, despite that, from the inside, knowing the how we rolled out this vaccination campaign, equity was really at the core of this rollout, making sure that every resident, every citizen of Louisiana, no matter who you are, where you live, how rural your community is, how urban, that you had access to vaccinations. And so if y'all remember at the beginning, pharmacies were really core to the plan. And that was why lots of people questioned, why did this vaccine go to healthcare providers first? And it was because pharmacies, are in communities throughout our state, very easily accessible to people with, so fewer barriers to getting into a pharmacy for vaccination, perhaps into a clinic or an office. So that was, the initial rollout. And of course, now every healthcare provider in the state has access to COVID vaccine. And you can see, again, looking at equity, again, this is something that we always track. We have maps to make sure that we're offering access. So throughout the state equitably. So for example, you can see if you look at the Black population in Louisiana, our population is 32 of Black individuals is 32.7 and 32.6. So, close to 32.7 of all vaccinations were administered to individuals, to Black African-American individuals. So that shows you there was a great, right? That's as you would hope and expect. If we had seen a gap there, for example, if the percentage of vaccinations were lower in the Black population, then we would have had to shift and do more promotion. But again, from the outset, there was lots of work to try to clear up any misconceptions or other concerns about the safety of the vaccine. And so I think it's really paid off. Same for the Hispanic population. If you look in Louisiana, the population is 5% Hispanic, and 6% of all vaccinations were administered to individuals. Hispanic individuals. So again, as you would hope and expect, that was those are the good matchups essentially of those vaccination rates. Next slide. This is, I think, a really good slide, and I'm fooling with my computer so I can blow it up. So these are, when we talk about vaccinations, the real issue is like, why is it important to be vaccinated? And there's lots of questions and controversy about that, right? And so we hear over and over again, the most important thing, right, is that by being vaccinated and boosted, it greatly reduces your risk of hospitalizations and death from COVID. It reduces your risk for long COVID. But now CDC is really starting, and they have been throughout the course of the pandemic, but I think really over the last couple of months with the Omicron surge, we're seeing some newer data. And so I just wanted to share that to you all. We just wanted to show that to you all. So this first slide, and I'm looking at my notes so I can make sure I'm explaining it clearly to y'all. So the first slide shows you your risk of, so if you look on the left, selected outcome or cases. So this is looking at cases. So people who are diagnosed with COVID, vaccinated versus unvaccinated with the primary series. So this isn't looking at boosters. It's just looking at people who at least had 2 doses of vaccine or 1 dose of Johnson & Johnson. So again, you can see the black line is unvaccinated. So we're looking at at all surges, but most notably, right, Omicron surge, since that's still the COVID that's circulating is still Omicron, and expected to remain Omicron over the next couple of months. So I think it's really important to see what happened with this last surge. So you can see huge increase, right, in the number or disparity in the number of people unvaccinated who were diagnosed with COVID versus people that at least had a primary series. But we did see, you can see September, August, September, that's when we had that Delta surge. You could see the vaccine was very protective even there against new cases of Delta. But with Omicron, so in December, January, when we started to see the Omicron variant circulate in our community, we started to see breakthrough cases at a greater rate than we had with Delta. So we saw an increase in people who were diagnosed with COVID, even in vaccinated individuals. But if you look at the bottom, at the stats at the bottom, vaccinated people still had a 9-time, I'll say it this way, unvaccinated people had a 9-time greater risk of dying from COVID than unvaccinated. So that's so vaccination, even just your primary series, still was very protective against death for individuals. And the next slide, next slide is going to show you a little different. Okay, so same information here. It's just the graph at the top is showing you deaths. So again, you saw a bump in an increase in deaths with the Omicron surge, even in people who were vaccinated with the primary series. And most of those individuals were older individuals, so 65 and above, and people with high risk or underlying medical conditions. The next slide is going to show you the impact of boosters. And this is something that, again, we've been talking about the importance of boosters with the Omicron variant. And so if you look at this slide again, we're looking at but looking at deaths, tragically. And so again, the black line or the number of people who died who were unvaccinated. And then if you look at the blue lines at the bottom, those represent vaccinated people. So with Omicron, again, vaccination is very protective and has been very protective against death. But then when you look at the primary series versus the booster, the little dotted blue line represents people who had primary series only. And the darker blue line represents people who got their booster dose. And so people who, when you compare people who were boosted versus unvaccinated people had a 21-time greater risk of dying from COVID during this Omicron surge than those who had boosted. So those who are boosted. So again, this is really pointing out the protective factor, and I think the graph at the top shows it visually very clearly. Of the booster. So vaccination itself is hugely important, and then getting boosted is even more so. Again, when we're talking about the Omicron surge, probably a combination of factors, doses, vaccine protection was starting to wane, considering the timing of Omicron. And then also Omicron had more immune escape because of the large number of mutations on the virus itself. So the vaccine was not quite as protective against that variant as as prior variants. Next slide. And then I'm wrapping up COVID to move on to a few things, checking my time, but to just point out too that we always monitor the most vulnerable group of individuals in our communities, and that's these nursing home individuals who live in a nursing home. We saw the devastation, right, with those first couple of surges in individuals who were in nursing homes, and just the tremendous increase in the number of cases and deaths. And so we always monitor that. And I think the good news is, you can see here again with vaccination, the decrease and the number of deaths, which is that black line. So even though we saw a little bit of a bump with the Omicron, it's still, much lower than at any other point in the pandemic when we saw spikes. And again, we saw an increase in cases, but we did not see the same increase in deaths. Next slide. And that's this decoupling, and that's what that term means. With previous surges, or in previous surges, when we saw the cases increase shortly after, kind of lagging indicators. So as cases increased, then we started to see an increase in the number of hospitalizations and deaths from COVID. And that was, pretty reliable, throughout the course of this pandemic until we got to Omicron. So again, there was that decoupling. We saw an increase in cases, but we did not see the rate of hospitalizations or deaths rise to that same degree. And again, likely as a result of vaccination, some immunity, and Omicron seems to make people not quite as sick as Delta and the prior COVID variants. However, just to point out, there are still people that continue to be hospitalized and die as a result of COVID, especially people who are older and people with underlying health problems. So vaccination cannot be emphasized as a protective factor. Vaccination and booster doses to keep people out of the hospital and to keep people, alive. And then we do track breakthrough infections and safety of vaccinations, of course. And so when we talk about Omicron, it's where I mentioned this is where we saw a difference. We saw more breakthrough cases than we had in the prior surges, especially Delta. So we again, something we monitor every week. Those not fully vaccinated account in the most recent tracking period, March 24th through 30th. About 61% of the new cases from people not fully vaccinated, about 80% of the hospitalizations in people not fully vaccinated, but about 50% of the deaths. And so this is showing you that I think this is where the point of the booster is really important, especially for older people, for all of us. Anyone 12 and above is eligible for a booster. But it's really critically important for people who are 65 and above, people with underlying health problems, people who are immune compromised. It's again important for all of us, but very important for those most at risk that they get that booster dose. And again, Omicron, which is going to circulate for the next couple of months, is not going away, and it's already proven that you can see that in these numbers. It's really important that people get that booster dose. And you wouldn't believe the people who still haven't gotten their first booster dose. The data that I was showing you previously was with the first booster dose. So of course, now we're on to the second booster for people 50 and above and those immune compromised. But, again, those that you interact with, your patients, your family, your friends, talk to them about making sure that they've gotten their booster dose. And then severe adverse events, there was a lot of concern about these vaccines, as y'all all remember, when they were first released, despite huge clinical trials and just millions, probably billions. I don't know the number worldwide that have been administered, but in the state we do monitor through our adverse event reporting system. We do monitor adverse events. Anyone can report an adverse event through the VAERS system. Those that actually met case definition after review has been 17. So in Louisiana, we've had 17 cases, and again, we talked about over 5 million doses administered of people who had what we consider an adverse event, 2 cases of anaphylaxis, 9 other, and 6 cases of myocarditis, and no deaths. And just to point out about myocarditis, to make sure y'all caught this update or recommendation a couple months ago. So now we know that the cases of myocarditis is a very small risk of myocarditis after an mRNA vaccine especially in younger men, so 16 to 30. As a result of that, and again, very, very rare, still small number, and people typically recover with no problems following the myocarditis, or has been the case so far. The findings, they've determined that spacing out the first and second dose of an mRNA vaccine should lead to fewer cases of myocarditis. So now the recommendation is, probably when most of y'all got your vaccine, like me, you waited 3 or 4 weeks between the first and second dose. If you got Pfizer, you waited 3 weeks. If you got Moderna, you waited 4 between those first 2 doses. And probably like y'all, we were I knew exactly my 4 weeks, and I wanted that vaccine. Now the recommendation is that you can wait and should wait, especially in younger men, 8 weeks between the 2 doses, and reduces the risk of myocarditis. And it might also lead, interestingly, to an increase in immunity. So anyone can wait 8 weeks, but it's most importantly recommended for people who are, or for young men, that they wait 8 weeks between the first and second doses. However, older people shouldn't wait. If you're 65 and above, you shouldn't wait. Get those doses closer together, and that's because you want people in that age group to get immunity quicker. But other than that, the newer recommendation is that you can wait 8 weeks, and should, again, in young men, between the first and second doses of your mRNA vaccine. Next slide. Okay, so that's it for COVID, and I guess I'll go through these, and then we can see if there's any questions about any of this. The next couple of slides, I'm going to talk about our hepatitis C elimination project. This was something that actually Kimberly Hood, that was my first introduction to our assistant secretary, is she ran this hepatitis C elimination project, working with Dr. Rebecca Gee, previous secretary. And so this was in 2019. It was innovative. I think we were the first state to do this, where we had, we are. So on the slide, a subscription model for hepatitis C treatment. And so the bottom line is there's a stated goal by the World Health Organization to eliminate hepatitis C. So y'all know hepatitis C causes or can cause chronic liver disease, cirrhosis, liver cancer, and about 1 out of 2 people with hepatitis C in Louisiana are unaware that they're infected with hepatitis C. So it's so very important that we, if we have a treatment, which we do now, we don't have a vaccination, but we do have treatment for hepatitis C. So the goal is in Louisiana that we diagnose 90% of people who are infected with hepatitis C and treat 80% of those people. And again, with the goal of eliminating hepatitis C. So as a result, Louisiana did something really neat where they worked directly with the pharmaceutical industry, and for a 5-year period, and we're entering the 3rd of those 5 years. Louisiana, we have a cap. We essentially, I'll say it in my layman's terms, we get all of the hepatitis C antiviral medication that we can use. And once we reach that cap, which we've reached for the last couple of years, we're not charged anymore. Our Medicaid program is not charged anymore for that medication. So the goal is, right, to every year diagnose and treat as many people as we can, because we reach that cap, and then everyone treated on top of that. There's no additional cost to the state Medicaid system for that medication. So that's the ultimate goal. Next slide. One maybe after this, and thank you. And so so essentially what this does is we have pushed the message out right over the last couple of years to physicians. First of all, test everyone in Louisiana for hepatitis C, especially those at high risk. We'll talk about it in a second. If they're positive, if they're under Medicaid, or if they're incarcerated through in a corrections system facility, they have access to the medication, again, at this capped price. And so this is from Medicaid. Individuals from Medicaid are in the DO system only. You have access to Epclusa, which is an antiviral medication. It is a 12-week course. It's a pill taken once a day. And the individual, at the end of that period, after a couple of months, they're tested to be sure that they did clear the hepatitis C infection. So about half of the people who develop Hep C will go on to develop chronic Hep C. So some people can eliminate it on their own, we're looking for all those people who are chronically infected with hepatitis C. We want to get them into treatment and cured. And Epclusa has a 98% cure rate, so very effective. And so that's the goal for the next couple of years, is to kind of ramp this up. You can see kind of really gone gangbusters right in 2019 when this subscription model was first introduced, and physicians and healthcare providers across the state were trained. But then COVID, as with everything else, is really impacted. And it's really impacted the progress towards this project. So we're again hoping, and we hope that you all will do your research and reach out to us to see where you might fit in with this. But again, over 10,000 people have been treated for Hep C since the project began, and over 600 providers have been trained. Next slide. And so we have wonderful trainers who will come out to your practice, wherever you work, and train staff on hepatitis C, on diagnosing and on diagnosing and testing. So Louisiana, this is one of the things that we're doing well. We've received an A+ for our efforts to limit hepatitis C in the state. And this is a new comprehensive analysis, and looking at all 50 states. And a letter grade is assigned based on all of these factors. And again, something that we can be really proud of in the state of Louisiana. Next slide. So again, this is just showing you, we're really proud of our A+ ratings. This is visually showing you that we are again, recognized as leading the nation in access to medication and a cure for hepatitis C. So just again, something to be very much proud of. Next slide is something else that we're really monitoring, and we were really happy in 2018 to be able to report that for the first time since the late 80s, Louisiana had fewer than 1,000 new HIV cases diagnosed. But unfortunately, what we're seeing is an increase. We're starting to see an increase. And so you can see from 2020 to 2021, so really in the heat of the pandemic, well, in 2019 to 2020, we saw a decrease. So, there's some of the factors that we're wondering there is that we weren't testing as many people because people might have had less access to HIV testing. So that's one potential, concern with the decrease. But what we're seeing now is from 2020 to 2021, an increase. And so 33% increase over this last year. And again, it's kind of hard, and this is something we'll continue to monitor. Is it that we had reduced testing capacity, so people didn't have access to testing, or are these in fact new cases? I will tell you, for example, in our region, so I work in the Acadiana or Lafayette region of the state, we're also seeing an increase in syphilis cases, and those are new cases of syphilis, or syphilis being diagnosed during their infectious period. So, we're concerned that we're seeing an increase in new and maybe older infections, STI infections that just were not previously diagnosed. So just to point it out that this is something that we'll continue to monitor, and you may hear more about this over the coming weeks and months. As an agency, we work to make sure that everyone's got this information. The big message here is test everyone. If you're in practice, talk to people about their risk factors. If they're at high risk for HIV infection, we have something called the Louisiana Health Hub. It's a great website. Dr. Shaquetta Johnson, who is I think on the webinar this morning, was really leading our HIV STD HEP program before she moved over to our immunization program. But really, that program under Dr. Johnson's leadership has developed a great health hub. And so one of the things that you can find through our health hub is prescribing information on PrEP. And so PrEP is an antiviral to help prevent people from becoming infected with HIV if exposed. So if you have individuals in your practice or that you encounter in your family or friend network, and they're at high risk for HIV infection, there is actually medication you can take once a day to, again, prevent infection. So we want people to know, we want providers to know, test for, all STI, HIV, syphilis, chlamydia, gonorrhea, most or many of them are silent. Test, and then again, treat if positive. And for individuals who are at high risk for HIV, consider PrEP prescribing. And again, Health Hub has tons of great information. Next slide. So one of our last topics to talk about is a big public health issue. And this is something, it's a national issue. It's not a Louisiana issue. And I think it's going to take all of us to really rally around and work to stop this, concerning trajectory, and that's drug-related deaths. Louisiana is experiencing an increase in overdose deaths, just like the entire country is. And so the slide on the right is showing you the national data for overdose deaths by, broken down by female and male. If you see the little squiggly lines, so the males, are dying at a higher rate from overdoses than females, but still, on an upward trajectory, and with both males and females. Louisiana. So if you look at the last two bullets, the rate in the U.S. from 2019 to 2020 was a 30% increase in overdoses in the country. Louisiana had a 43% increase over that same period of time. And in talking with our epidemiologists about this, Louisiana always outpaces the rest of the country, or has been for the last few years, outpacing the rest of the country in overdose deaths. So while the nation is seeing an increase, Louisiana is seeing an even sharper increase in the number of overdoses. Next slide. We've made some progress in the prescribing practices, but we're still, as a state, prescribing more opiates than most others. So in 2020, Louisiana was ranked in the top 5 opiate prescribing states, which is, again, why I'm really happy to talk with nurses, nurse practitioners. So again, if you in your practice, this is something to monitor. I do know that I'm sure healthcare providers around the state have heard about the new prescribing practices. There are actually now restrictions on prescribing practices, and which is, I think, that plus education and awareness has led to some improvements. And so even though we're in the top 5, we have made progress. So if you look at, from 2016 to now, we've made improvements, and providers have written fewer opiate prescriptions. And so we're seeing that decrease, which is a good thing. But over the next couple of slides, we'll show you the impact of that is that, so people, the thought is, right, that individuals who are using opiates, we're getting them, from prescriptions, as the prescribing practices have really become more strict across the country. Now, illicit drugs are gaining when we're talking about overdose deaths. So next slide. So the drugs that are leading the overdoses and deaths are synthetics, and so and that's frankly what this is showing you. The slide on the left is in the U.S. From 2017 to 2021. The poisoning deaths from synthetic opioids, fentanyl, the most common. And then on the right, it shows you where we are in Louisiana. And if you look at Louisiana, the lines represent the year. So the blue line is 2019, 2020 is that green line, and then 2021 is the orange line. So again, we're increasing. And this is just a different way to look at the same data. This is looking at it by month in Louisiana. And we have an opioid surveillance program. Again, just like our COVID dashboard, you can get tons of information from Louisiana Department of Health, from our opiate dashboard. You can get information by parish, by drug. It's really great. If this interests you, I would just definitely recommend you go to that website to get this information. But again, I think the important thing is to talk about is opiates from deaths from these synthetics. So these are drugs made in China, made on the street. It's not prescription fentanyl. These are illicit drugs that someone's making. And often what is found is that, first of all, fentanyl is more potent. It's easy for these kind of bad actors to get their hands on. And so fentanyl is I'm learning, because again, here in the Acadiana region, we're partnering up with our coroner's office, our human service district, law enforcement to try to figure out, our hospitals, universities, what can we do to turn this tide around and save people's lives. And as I'm learning, oftentimes the user doesn't know, probably most of the time, that their drug is laced with fentanyl. For example, it was Adderall. People actually can press pills on the streets, essentially. And so someone might think they're taking a prescription Adderall that they're buying from someone off the street, right? Let's say they help them study, these college kids. So this is something they're trying to share the message on college campuses. Some student, might again buy Adderall, not getting it from the pharmacy prescribed by a doctor, but yet buying it off the street, and that Adderall might be laced with fentanyl. It doesn't take much, especially to a naive user, to overdose. So that's just one little example. So the bottom line is these drug-related deaths are driven by synthetic or these homemade drugs and made. China is a big producer of these, but can be made on the street. Increased use of fentanyl, oftentimes without the person knowing. And then COVID also, really caused a lot of just really had traumatic consequences on so many levels. But you can see here, I think leading to drug related deaths, and also suicides that we're seeing an increase in. People more stressed and anxious. People are isolated. We talk about drug users, they're using drugs alone. People, often these individuals who had a substance use disorder did not have access to their regular support groups. So, all of these things, since this isolation, social distancing, someone might have had trouble with technology, decreased social supports. These are all some of the thought behind these drug-related deaths and these increases. And so again, it's going to take a community to rally behind this. And I don't have stats on this, but again, as we're seeing an increase in most in lots of mental health and mental health disorders too. Again, suicides are another topic that we're really concerned about in public health. And so again, I think it's going to take all of us to address these, because you can see lots of social and other isolation issues are leading to these tragic outcomes. Next slide. And again, hopefully on a good note, this is something as a state we're embarking upon. We do this every couple of years. It's a state health improvement plan. Again, it's to help guide as an agency, LDH, the Office of Public Health, where do we put our efforts? What do we want to put our efforts behind to try to move the needle and improve outcomes in our state? And so in order to do that, our agency really gets feedback from the local level. And so each region of the state has a state health assessment, and then an improvement plan. And so we're embarking on an improvement plan, which should be released in the fall. And so that is when we'll, talk about the top priorities that as an agency that we're gonna work to address. But we don't do it alone. Again, most of us have healthy community coalitions, and so we depend on our stakeholders at the parish level, at the regional level, knowing that that's where we're going to get and make the most impact is at that local level. And so far, based on meetings that have been held, these assessment and planning meetings, the priority areas you see below, chronic disease, we know the rates of heart disease, cancer, stroke in our state are high, and how do we again look at those preventive measures to decrease those rates, reduce tobacco smoking, blood pressure control, diabetes, better control diabetes. So looking at chronic disease, behavioral health, we just talked about, maternal and child health. We know there's a maternal morbidity, and there's a huge disparity there. How do we make impacts and improve outcomes for women and children in our state, especially when we're talking about minorities, and again at those huge disparities? How do we correct that? And that's work that has been ongoing. And then just overall community safety. So those are some of the data points. And again, there's something for any of you who are interested in looking at in your parish or in your region of the state. What are some of the the health rankings? And I can tell you, some of y'all might apply for grants, or you might have students who work on research projects. Where do you go? Or where can you go to find the latest access to data on again any health topic that you can think of in the state? And we have something called My Sidewalk. It's released just a couple of years ago, a year or two ago, and it's you see it on this slide. It's a data visualization. It's very easy to use. It's updated, but again, I think it's great if you're working on a grant, if you have students who are working on a project. I've been with the Office of Public Health for 21 years, and this started off with parish health profiles. We had a paper, a paper version of this, and not nearly this detailed. This is tremendous. Everyone's got this access at their fingertips, and so anything that you're interested in, we've probably got a dashboard for it with updated data. And I think again, it's often a hidden gem that we got and collect in the state through LDH, through the Office of Public Health. So it's there for your perusal. And again, that's my last slide. I hope this was helpful and informative. I think LDH is a great agency to work with, but we couldn't do it without our community partners. And so I'm really hoping that something spoke to you all and that you reach out to your local office of public health. So I'm a medical director here in the Acadiana region, the 7 parishes of Acadiana. And I have a counterpart in every region of the state, or just about every region. We're hoping to hire someone in the Monroe region soon. But I have a counterpart. I work with regional nurse managers, and so should be pretty easy to find how to contact us. And so I would urge you to reach out to us if you want to volunteer. Louisiana Volunteers in Action is a great place to volunteer because we're entering hurricane season. We're always looking for people, especially our wonderful nurses, social workers, anyone who might be represented on this call to work with us in caring for our community, especially the most vulnerable. That's it for me.
Thank you so much, Dr. Tina. This was amazing. And you're getting a lot of shout outs on our chat. So, and a lot of congratulations on the state's work to eliminate Hep C. That's really remarkable and something that we can be proud of.
Yes.
So
thank y'all. Yep. In fact, again, Kim Hood and I chatted with her last night about that. And I really wanted to highlight that because I think it's really important. And again, it's something that it's some action, right? As healthcare providers, we all want to help improve the lives of the patients that we interact with. And so this is actually some action that we can take that can change someone's life.
Absolutely. So we have 2 questions for you. The first one comes from Lorinda Seeley. She wants to know, how reliable are the at-home testing kits for COVID?
Sure. Yeah, it's a great question. And so the at-home test kits are antigen test kits. So that's one. So the antigen tests, the at-home kits are pretty good. So it's a few different little caveats to it, right? So if you come through a COVID testing site where we perform an antigen test, so it's healthcare provider witnessed, it's even more effective or accurate because you have someone kind of walking you through it. So I will say, number one, the at-home kits can be a little tricky. Make sure you know how to use it before you read the instructions well. Because our nurses here, we've looked at them and thought, okay, some are more complicated than others. So one is going to be the technique that you use. Make sure you're following the directions. But if you follow the directions accurately or well, these antigen test kits are very effective at detecting COVID, especially if you're symptomatic or you're exposed. So if you're just taking it as a screening, then we recommend it. You have to test frequently because there is a rate of false negatives. But if you've got symptoms or you were exposed and you test positive, you can be pretty sure you've got COVID. The more concerning when you look at the rates of sensitivity and specificity or with the false negatives. And so again, if you're symptomatic and you're just trying to decide, right, if you want to go to an Easter, if you're going to be around family and friends, some who might be at risk and you want to test, then I would say if you have an at-home test kit, test every day for a couple of days. That's going to give you, more accuracy. If you're symptomatic and you test negative, test again the next day just to be sure. The PCR is a gold standard. It's a send out. It takes about 24 hours at times to come back, but in general, the at-home test kits are very good. Especially they were really designed for people who are symptomatic or exposed to detect COVID.
Thank you. Our next question comes from Dr. Cynthia Bienemy. When someone tests positive, or when someone has tested positive, they were not told which variant they were infected with. So how are the variant surges identified?
Sure. So again, a great and interesting question. So right now we don't have a way. So if you test positive for COVID, there's no way to tell if you've got Omicron or Delta or Omicron BA1 or BA2. You just know you have COVID. So what we do as a state, we send in a sampling of all of the COVID tests that are collected, and those are tested through the CDC lab network. And so they do sequencing, and that sequencing can take a couple of days or weeks. But that is how we as a state are informed as to what's circulating essentially in our state. We get a percentage. And so we actually, and again, that's something that you can pull from our data from our website. You'll see, you can actually track. And so you started for example, Delta, we saw as the percentage of Delta infections started to decrease in the Omicron, and our rates of Omicron started to increase through the sequencing sampling. So it's just essentially an estimate of what's circulating in your state, and that's how you might know. So right now, the chances are it's Omicron. If you test positive, it's 99, and I'd have to pull it up. 100% of what's circulating in our state is Omicron across the country. Well, we're starting to see some shift is between BA1 and BA2. And that BA2 is the same, it's all Omicron. It's just a subvariant. So it's a little different. If you had Omicron, you should be protected even with this BA2 version. And I just talk a little bit about BA2 because that's what you're hearing about in the UK, right? I don't know if people are hearing a little bit about that it may be a little bit more contagious, easy to transmit, this BA2 version. So we're waiting to see if we're going to see here in the US, if we might see a little bit of an increase, if we have a more contagious form of Omicron starting to take over. And so right now in the state, and again, I'd have to look, I think it's about 60% estimated that about 60+% is BA2 circulating. So we're starting to see that shift to this newer Omicron, if you will, and we'll probably continue to see that shift. It'll probably outcompete the original Omicron if it's more contagious. But again, for the general public, I think if you test positive now, it's probably Omicron. The reason these sequencings, for many reasons, but one of the reasons the sequencing is so important is it does help to guide therapy. And so y'all all heard, we all know about these infusions, right? And sotrovimab was the infusion that was effective against Omicron. So the federal government pulled all the other monoclonal antibodies away and said, you've got to use sotrovimab. That's what works against Omicron. So now we're learning with BA2, sotrovimab is not as effective against BA2. So the federal government just in the last couple of days are pulling the shipments of sotrovimab and sending us another monoclonal antibody, which is the effective treatment for this Omicron BA2. So it's very confusing. So it is important to know what variants are circulating. I think probably most importantly in this, when we're talking about these two, when we're talking about Omicron, is because it helps to guide therapy. But it's all back to sequencing. It's all done at the CDC and through that lab network, and we just report the percentage. And so that's how you know what's circulating, and you just kind of estimate based off of that what Omicron or what COVID you might have.
Okay.
Very long answer.
Well, it changes, right? I was going to say, I just remember when the CDC was giving healthcare providers 4 and 5 updates a day to try to keep everyone informed. And so we could probably expect to continue to receive those notices as the evidence becomes available.
Sure. And a lot of healthcare providers, for example, with this shift in the monoclonal antibodies, it's been very different. Because through the Delta surge, we had great access to monoclonal antibodies. There were a couple that were effective, and then all of a sudden there was this big shift. And so it is important as healthcare providers to know that's why you see these shifts in product availability, is because they're frankly trying to keep up with the effective products. And so then it's a supply and demand issue. So when the Omicron surge started to increase, the provider saying, okay, I want to send my patients for an infusion. Where can they go? Well, we were only getting about 200 doses of sotrovimab as a state every other week. So it was very much prioritized for transplant patients, people at most at risk. So if you had a patient, even an older patient with COVID, providers were saying, okay, wait, why can't I get them an infusion? Well, it's because it was in such short supply.
Thank you for explaining that. Our next question comes from Samantha Summers. And she says that she hasn't opened a home kit yet, but she wants to know how easy are the directions to follow for those who have literacy issues.
Well, that's a problem. That's a concern we have too. And so we actually just a couple of days ago, because we've got more at-home test kits in, and we're going to start distributing them, trying to test it ourselves and see if we need to. We as an agency, the Office of Public Health, developed some a little bit more simple instructions to go along with those test kits. But how do you get that out to people, right? There are YouTube videos that are a little bit more helpful. So it's, you're right. And there are some at-home test kits that are easier to follow than others. And we have a lot of concerns about, individuals' literacy problems. I'm hoping that as time goes, they'll become more and more easy to follow. I don't know. I know, and I know I saw a text from a great partner at Ashland Lafayette General, Karen Weibel. And so I know just throughout the state, these testing centers that we all manned were so helpful and beneficial to people, because testing is really key to so many things. It's key to getting you back to work and school, protecting your family. And so I think this at home is probably going to be the way we move forward with this. And again, I do have concerns about people with health literacy issues. And so we'll just try to keep making those instructions as simple as we can, but hopefully the test kits will become, more simple.
Right. Yeah, I have to tell you, I received my free test kits from the federal government, and I had to use one. And I have to tell you, I had to read those directions several times to make sure I was doing it right. So, so I have those concerns too. Our next question comes from Terry Dilks. So good to see you, Terry. How strong is the data on the fourth vaccine? So I guess that booster.
Yeah,
no,
yes.
Sorry, the second booster, right?
The second booster, right. And so I think it's the FDA. So this was this is an approval that came from the FDA, that the fourth booster was safe and recommended for people 50 and above and people who are immune compromised. CDC's recommendation on that, their recommendation is that if you're 50 and above, you get the booster if you have underlying health problems, and if you don't have any underlying health problems, if you're 65 and above. And then, of course, people who are immune compromised. So it's interesting, even CDC and FDA's recommendations are a little bit different. So we're learning from other countries that have implemented this second booster, over the last couple of months. And so I think we'll learn more. I know some of the data is showing that immunity might wane even with that second booster. You might see after several weeks, might start to see a decrease in protection. So I don't think anyone knows how long these boosters are going to be effective, but I think that the goal here is to try to protect the most at-risk people from hospitalizations and death. And the best way to do that, especially people who are immune compromised or older, is to boost their immunity to give them a better protection in advance of the next surge. And we don't know when that would be. So it's just really tricky. But I think the best evidence that we've got is, again, protecting those most vulnerable is going to be the way forward until we have more data on how long these vaccines the immunity will last. I know it's kind of a non-answer, but I think we still don't know a whole lot yet. We're still monitoring what's happening in some of these other countries, and how long that level of protection, in fact, lasts.
I keep reminding our members that a lot of this we're learning as we go, and so we just have to keep learning as we go.
Yeah, exactly. And I think, again, those slides I go back to, which I think is a great visualization, people who are vaccinated and boosted. And so especially those most at risk, when you boost them again, that's the most protective. And so, again, for those most vulnerable, immune compromised and older people, I think it's of course needs to be strongly considered and again, in advance of the next surge. And we don't know when that might be.
Thank you. Our next question is from Christine Brennan, and I'm not sure if I'm going to ask this correctly because I'm not quite sure what this is about. But are there any steps planned to formally coordinate the activity of the state licensing boards and LDH if the only obligation is to disseminate public health notices to the licensed provider?
Now, I don't know. I may have to get that question in writing so I can get an answer. So I can do some research. If you don't mind, if y'all send that to me in an email.
You bet. We'll be happy to do that. And then I have a question. So I guess it's personal privilege for me to ask this. But I feel like since really COVID began, we have been inundated also with natural disasters, Louisiana. And even our friends in northern part of almost our whole state experienced the ice storm and the disruption, of course, to healthcare and to really our daily lives. Are we looking at what impact that would have on people's access to care?
So I think I'm sure someone is looking at the data to show, you mean like with natural disasters, how does that limit access to healthcare? Yeah, I think we all know it does. Whether or not someone's doing a formal study, I would expect they are. I guess silver linings with COVID, for me, it's relationships and figuring out how to work outside of the four walls of these healthcare system deliveries to impact health and improve health. I think another one is telehealth. And so, the access to that even though a practice or an office might be shut down, that people still have access through telehealth to their healthcare providers. So I'm certain, I would suspect that someone's looking at the data, but I think in the meantime, to try to, through all of these all of our licensing boards and our agencies, to try to figure out how to continue to, I think, especially in times of limited access, to promote access through telehealth is going to, the only thing that I can, for example, I helped, within the post Ida in the Region 3 area of the state. And, it is, access to pharmaceutical, to pharmacies to get medications, hospital access, ER. I can tell you in the state of Louisiana, we have a tremendous trauma network, which would be a great agenda item for you all for another conference. All those things are tracked. And you're right. When you have natural disasters, ER access, you have longer transport times, less availability to things, like medications to dissolve clots if you have a heart attack or a stroke. All of those outcomes are affected. And I do know that that following the storm, for example, we did track outcomes, and you could very clearly see this was especially ER, emergency department type access. But yeah, so we are tracking that. I know for sure that has been tracked.
Great, thank you. Well, we appreciate you so much for joining us today and giving us this incredible information. On behalf of the Louisiana Action Coalition, we really appreciate it.
Thank you all for everything that you do.
Thank you.